Have you ever stopped to think how your body just handles something as vital as your blood pressure, ensuring everything runs smoothly, like day in and day out? Today, on the deep dive, we're doing this especially for you, our listeners tuning into KMR Advice. We're plunging into a system that's absolutely central to all that, the Renin-Angiotensin system, or RAS. And we're going to focus in particular on a really fascinating critical class of meds that target it, ACE inhibitors.
Yeah, absolutely. It's the system working constantly kind of behind the scenes, regulating some really fundamental things, not just blood pressure, like you said, but also your fluid balance, even your electrolytes. And, for those of you following KMR Advice, especially our medical students, this discussion should feel, well, pretty familiar, like an extension of the deep medical explanations you find on the KMR Advice YouTube channel.
Exactly. So if you find this deep dive useful and you want more of this kind of detailed stuff to help your learning, please do share it, subscribe to the KMR Advise channel, and definitely hit that bell icon so you don't miss future deep dives. Okay, so the information we're unpacking today comes straight from our detailed notes on RAS pharmacology, the kind of stuff we get into on KMR Advise. Our mission here really is to pull out the key insights about this system and, crucially, how ACE inhibitors work. We want to give you a clear, engaging understanding, much like you'd find on KMR Advice. Okay then, let's get into it. At its heart, what exactly is the RAS all about?
Well, at its core, you can think of the Renin-Angiotensin system as this sophisticated hormonal control center. Its main job, regulating your blood pressure, the amount of fluid in your bloodstream, your plasma volume, and that critical balance of electrolytes like sodium and potassium. And the real main player, the one calling a lot of the shots, is this small but powerful molecule called angiotensin II, Ang2 for short.
The angiotensin II, right, got it. What makes that molecule so important?
Well, Ang2, it really packs a punch in terms of its effects. It's a potent vasoconstrictor. Think of it like squeezing blood vessels tighter. That narrows them, which, increases pressure. And it also acts on your adrenal glands, telling them to release aldosterone. That's a hormone that's super important for how your kidneys manage sodium and potassium.
Wow, okay. So a really influential molecule then. So understanding this is, well, crucial for anyone in medical training following KMR Advice. Now, I gather this knowledge didn't just appear overnight. Can you give us a quick history lesson? How did we figure out the RAS?
Yeah, absolutely. It's quite a story. It really starts back in the early 20th century. Scientists noticed that extracts from kidneys had this pressor effect that could raise blood pressure. Later, they identified an enzyme. They called it renin, and renin acted on a precursor protein, angiotensinogen, to make something called angiotensin oct. Now, initially, they thought maybe ANI was the active thing, but then they discovered it gets converted to the much more potent angiotensin II by another enzyme, the one we now know as ACE, angiotensin converting enzyme. Understanding that whole pathway was, well, revolutionary. And it directly led to the discovery of ACE inhibitors, which have completely changed how we treat things like hypertension and heart failure, topics we definitely cover on KMR Advice.
It's fascinating how it built up piece by piece, like solving a puzzle. So let's dig into the system itself. What are the main bits and pieces, the components and pathways within the RAS that our KMR Advice audience really needs to know?
Right. So the RAS basically works through two main routes. There's the circulating RAS, that's hormones traveling in the blood. And then there's the local or tissue RAS, where components are made and act right inside specific organs. Let's maybe start with the circulating system first, outline the key players there.
Sounds good. Let's have it.
Okay, first up, angiotensinogen. This is the precursor protein. It's made in the liver, an alpha-2 globulin. It doesn't really do anything active itself. It's just the starting material. Then you've got renin. This enzyme comes from special cells in the kidney, the juxtaglomerular or JG cells. Renin doesn't hang around long in the blood. Its half-life is only about 15 minutes. Its job is to chop a piece off angiotensinogen, creating angiotensin I. Now, angiotensin I, that's a decay peptide, 10 amino acids, and it's generally thought to be pretty inactive, mostly just a stepping stone.
Okay, so renin acts on angiotensinogen, makes this less active angiotensin I. What's the next crucial step our KMR Advice viewers need to grasp?
All right, this is where ACE comes in, angiotensin converting enzyme. ACE is mostly found on the inner lining, the endothelium of blood vessels, lots of it in the lungs, particularly. ACE acts like molecular scissors again. It converts angiotensin I into angiotensin II. And Ang2, as we said, that's the active one in octopeptide, 8 amino acids. Very short half-life, though, about a minute, because it's so potent and acts quickly.
Short-lived but powerful.
Yeah.
Are there other related angiotensin molecules floating around that are important for our KMR and Advice learners?
Yep, a couple more play roles. Angiotensin II can get broken down further by enzymes called aminopeptidases to form angiotensin III. That's a heptapeptide 7 amino acids. Ang3 is generally less potent than Ang2 for most things, but it's still pretty good at stimulating aldosterone release. And then further breakdown can make angiotensin IV a hexapeptide. This seems to have effects in the brain and peripherally, acting via something called the AT4 receptor. And finally, there's a group of enzymes called angiotensinases. They're nonspecific, basically degrading all these angiotensin peptides, helping keep levels in check. It's this whole system of activation, then breakdown to maintain balance, really key for those studying on KMR advice.
A cascade of making things happen, then cleaning up afterwards. Makes sense. Now, you also mentioned a local or tissue, RAS. How's that different from the circulating system, and why should our KMR advised audience care about it?
Well, what's really interesting is that lots of organs, not just the liver and kidney, but the heart, blood vessels, brain, adrenal glands, they can actually make all the RAS components themselves, locally. This means that right within those tissues, angiotensin II and other peptides can be generated and exert effects right there. These local systems are super important for regulating things like blood flow within that specific organ, cell growth, apoptosis that's programmed, cell death tissue remodeling, and even fibrosis, which is scar tissue formation. Understanding these local actions adds, another layer for conditions we talk about on KMR Advice.
So localized control. That is significant. Now, the term prorenin popped up in our notes. How does that fit into this complex picture for our KMR advised viewers?
Right, prorenin. It's the precursor to renin, the molecule before it becomes active renin. And interestingly, there's actually way more prorenin in the blood than active renin. Prorenin can be activated in two main ways. One is enzymatic, other enzymes called proteases, basically snip it irreversibly into active renin. The other way is non-enzymatic. This happens when prorenin binds to a specific receptor, the prorenin receptor, or PRR. This binding kind of changes prorenin's shape, activating it, but this way is reversible.
So prorenin isn't just sitting there waiting. It can be activated by binding to this receptor, too. That's an important detail for our KMR advised students.
Exactly. And what's really intriguing about this PRR receptor is that when it gets activated, it doesn't just lead to Ang2 production, it also kicks off signaling pathways that are completely independent of Ang2. These PRR signals can directly influence things like cell growth, fibrosis, apoptosis, so it highlights a more complex role for prorenin than just being a renin source. It's an area of active research, adding more nuance, which we like to touch on at KMR Advice.
This system is definitely intricate. Maybe to help our KMR advised listeners keep track, could we just quickly summarize the main angiotensin peptides we've covered and their primary jobs?
Sure thing. So angiotensin II, octopeptide from Ang-I via ACE, main jobs: constricting blood vessels, releasing aldosterone, promoting cell growth. Then angiotensin III, heptapeptide from Ang2, focuses more on aldosterone release, less potent vasoconstriction. Angiotensin IV, hexapeptide from Ang3, seems involved in cognition, maybe some vascular renal stuff via the AT4 receptor. And then there's angiotensin 1 to 7, another heptapeptide made from Ang1 or 2 by a different enzyme, ACE2. Its actions generally oppose Ang2 vasodilation, anti-growth, anti-clotting effects.
That's a really helpful rundown, especially for our KMR advised audience trying to cement these ideas. Okay, let's zoom in on angiotensin II now, given it seems so central. What exactly does it do around the body?
Right. Ang2 has a huge range of effects, especially on the cardiovascular system. It directly squeezes blood vessels vasoconstriction. Plus, it ramps up the effects and release of norepinephrine from the sympathetic nervous system. Both actions raise blood pressure and peripheral resistance. Interestingly, it also acts directly on the heart muscle. It helps calcium get into the cells, which makes the heart contract more forcefully. But, and this is a big but, long-term, Ang2 contributes to harmful cardiac remodeling. It causes hypertrophy cells getting bigger, hyperplasia, more cells, and fibrosis, scar tissue. This is really relevant in heart failure and after heart attacks, things we cover a lot on KMR Advice.
Okay. So a bit of a double-edged sword there. Good acutely, maybe, but bad chronically for the heart structure. What about other smooth muscles?
It can cause contraction of visceral smooth muscle, like in the gut, but honestly, compared to its effect on blood vessels, that's generally seen as less physiologically significant overall.
Got it. Aldosterone, you mentioned it earlier, key hormone for KMR advised learners. How does Ang2 trigger its release?
Ang2 is the main physiological signal telling a specific part of the adrenal gland, the zona glomerulosa in the cortex, to make and release aldosterone. Aldosterone then travels to the kidneys and acts on the tubules there. It makes the kidneys reabsorb more sodium and water back into the blood, and at the same time, it makes them excrete potassium and hydrogen ions into the urine. This is absolutely critical for regulating electrolytes and blood volume, something we definitely emphasize on KMR Advise.
And the kidneys themselves, any direct Ang2 action there?
Yes. In the proximal tubule, Ang2 boosts the sodium-hydrogen exchange, so more sodium gets reabsorbed early on. It also generally tends to reduce blood flow to the kidneys and lower the glomerular filtration rate, the GFR that's a key measure of kidney function. Although there are exceptions. In some situations, like cirrhosis or renal artery problems, Ang2 can actually help maintain GFR. Understanding those nuances is important for folks studying on KMR Advice.
Okay, moving up to the brain, what does Ang2 do there?
Well, in certain areas of the brain, Ang2 stimulates thirst, makes you want to drink. It also triggers the release of ADH, antidiuretic hormone, or vasopressin. ADH then tells the kidneys to hold on to more water. On top of that, Ang2 increases the activity of the central sympathetic nervous system, adding another layer to its blood pressure-raising effects. These brain actions really show how widespread the RAS influence is a key concept for our KMR Advise audience.
And lastly, peripheral sympathetic structures. How does Ang2 affect them?
It basically turbocharges them. It enhances norepinephrine release from sympathetic nerve endings all over the body. It also directly stimulates the sympathetic ganglia nerve cell clusters and the adrenal medulla, the part of the adrenal gland that pumps out epinephrine and norepinephrine. All of this boosts overall sympathetic activity.
Wow, so angiotensin II is really orchestrating a whole symphony of effects to keep blood pressure and fluid balance up. Now, you mentioned receptors. Can you break down the main types and how they mediate all this?
Right, the receptors are key. The main ones are AT1, AT2, AT4, and the MAS receptor. The AT1 receptor is the big one. It's found everywhere: blood vessels, heart, kidneys, brain, adrenals. Angiotensin II binds most strongly to AT1, and this receptor mediates almost all the classic Ang2 effects we've talked about: vasoconstriction, aldosterone release, cell growth, all that stuff. It works through a signaling pathway involving GQ proteins, activating phospholipase C, leading to messengers like IP3 and DAG inside the cell. Think of AT1 as the main action receptor for Ang2.
Okay, AT1 is the main action receptor. What about AT2? How does that compare?
AT2 is different. It's found more in fetal tissues, though adults have it too, especially in blood vessels. And interestingly, its actions seem to be largely opposite to AT1. AT2 activation tends to promote vasodilation, relaxing blood vessels, apoptosis, and inhibiting cell growth. Both Ang2 and Ang3 can bind to AT2.
So almost like a counterbalance, a break on the system. That's a really interesting angle for our KMR Advise listeners.
That's generally how it's thought of, yeah. A counter-regulatory role. Then you have the AT4 receptor, found in the brain, kidneys, heart, vessels. Angiotensin V seems to be its main ligand, and it's linked to cognition and maybe vascular effects, possibly via an enzyme called IRA. And finally, the MAS receptor binds angiotensin 1 to 7 and mediates its generally protective effects, like vasodilation and anti-growth actions. So the key takeaway here, especially for the KMR Advise audience, is AT1 drives most of the main Ang2 effects we worry about clinically, while AT2, MAS, and maybe others provide some balance or opposing actions.
Understanding those receptors is absolutely vital for figuring out how drugs can target this system, which we'll get to. But first, let's talk pathophysiology. When does this normally helpful system go wrong, and what happens then?
Well, the RAS is fundamental, like we said. Ang2 is the main trigger for aldosterone. The whole system maintains electrolyte, volume, and pressure balance. Now, renin release, that very first step, is tightly controlled. There are 3 main signals the body uses to decide when to release more renin.
Okay, what are those triggers, the ones our KMR Advise viewers should lock in?
First, low blood volume or low blood pressure. This is sensed directly by special baroreceptor cells right inside the kidney, the intrarenal baroreceptor. Second, low sodium and chloride levels reaching a spot in the kidney tubule called the macula densa. This triggers something called tubuloglomerular feedback, which influences renin release. And third, increased sympathetic nervous system activity, specifically activation of beta-1 receptors on those JG cells that make renin. So multiple checks and balances.
Right, so the kidney is really ground zero for sensing these changes and kicking off the RAS response. Super important point for anyone studying on KMR Advise.
Absolutely. Now, when the RAS gets chronically overactive, that's when problems arise. It plays a huge role in renovascular hypertension, high blood pressure from narrowed kidney arteries, and also in many cases of essential hypertension, the common kind where the cause isn't obvious. In these situations, that sustained RAS overactivity contributes to all that bad remodeling hypertrophy, fibrosis in the heart and vessels. It also drives secondary hyperaldosteronism, too much aldosterone, often seen in heart failure or kidney artery stenosis. And don't forget, Ang2 acts in the brain too, influencing thirst, hormones, sympathetic outflow, so dysregulation can have widespread effects. Understanding these disease roles is why targeting the RAS pharmacologically is so critical in medicine, tying back to KMR advice content.
Okay, that makes perfect sense. Understanding the problems highlight why drugs targeting the RAS are so useful. What are the main types of drugs used to interfere with the system?
There are several main classes. You've got sympathetic blockers, which can indirectly reduce renin release. Then direct renin inhibitors, they block renin itself, starving Ang-I formation. Then AC inhibitors, which we're focusing on, they block Ang-I conversion to Ang-2, very relevant to KMR-advised discussions. Angiotensin receptor blockers, ARBs, they block Ang-2 from binding to the AT1 receptor. And finally, aldosterone antagonists, which block aldosterone's effects downstream.
That's a great map of the different strategies.
Oh,
Okay, let's really zero in on ACE inhibitors now. Captopril is often mentioned as the prototype. What's the story there? How did it come about?
Yeah, the story of ACE inhibitors is pretty cool. Actually started with snake venom. Scientists noticed certain pit viper venoms lowered blood pressure. They isolated a peptide called teprotide from the venom, which was the first ACE inhibitor found. Problem was you couldn't take it orally, which really limited its use. So researchers set out to make an orally active version, and that led to captopril. It's a dipeptide analog, mimics two amino acids, and it has this key sulfhydryl group that helps it bind and inhibit the ACE enzyme. A major breakthrough, paving the way for treatments we discuss often on KMR Advice.
Wow, from snake venom to an oral pill. That's quite something. So how exactly does captopril work pharmacodynamically? The mechanism our KMR Advise audience needs to understand.
Okay, so captopril and all ACE inhibitors, their main job is blocking that ACE enzyme. This stops the conversion of inactive angiotensin the first to the very active angiotensin the second. Less Ang2 means less vasoconstriction and less aldosterone release. But that's not all. ACE also breaks down bradykinin and substance P, substances that actually dilate blood vessels. So by inhibiting ACE, you get higher levels of these vasodilators hanging around. The overall result: lower blood pressure, mainly by reducing the resistance in peripheral blood vessels. And importantly, it does this usually without messing with cardiac output much or the body's normal blood pressure reflexes when you stand up. So minimal postural hypotension, which is a good thing for patients.
Right, that point about postural hypotension is key.
Hmm.
Clinically, what effects do we typically see when patients take ACE inhibitors?
Yeah. Well, the initial drop in blood pressure can be more dramatic in people who are, say, sodium depleted or have really high RAS activity to start with, like in heart failure or renovascular hypertension. But the long-term blood pressure lowering effect, that seems to happen pretty broadly, even in people whose renin levels weren't initially high. This suggests that blocking the tissue RAS and maybe those bradykinin effects are really important for the sustained benefit over time. This wider effectiveness is why they're cornerstone therapies for conditions we cover on KMR Advice.
So maybe a bigger initial splash in some, but a solid long-term effect for many. Okay, let's talk pharmacokinetics, how the body handles them. Our notes compare several common ACE inhibitors. Can you walk us through some key differences in absorption, metabolism, elimination?
Sure, if you look at that comparison, you see differences right away in structure. Captopril has that sulfhydryl group. Others like enalapril, lisinopril use carboxyl groups. Fosinopril has a phosphonate group. A really key difference is active drug versus prodrug. Captopril and lisinopril, they're active as soon as you take them. But enalapril, fosinopril, perindopril, ramipril, they're prodrugs. The liver has to convert them into their active form first. Bioavailability, how much active drug actually gets into your system, that varies too. Peak action time differs. Captopril's relatively quick. Half-life varies a lot, affecting dosing frequency. Captopril's shorter, perinopril's longer. How they get eliminated, mostly kidneys for most of them. But fosinopril is interesting. It has dual elimination, kidney and liver, which can be useful sometimes. So all these things, duration of action, daily dose, they all differ based on these pharmacokinetic properties. Important stuff for clinicians choosing the right drug, as we discuss on KMR Advice.
Okay, so they all block ACE, but these kinetic differences matter for choosing the right one. Now, side effects. No drug is perfect. What are the common adverse effects with ACE inhibitors that our KMR Advised listeners absolutely need to know about?
Right, side effects. Hypotension, low blood pressure, that's probably the most common, especially when starting or in patients already on diuretics or with heart failure. Start low, go slow is the rule. Hyperkalemia, hypotassium, that's another risk, especially with kidney problems or if patients are taking potassium-sparing diuretics, NSAIDs, or beta blockers. Got to watch those potassium levels. Then there's the cough, that characteristic dry, hacking cough, thought to be due to bradykinin substance P buildup in the lungs, not dose-related usually, and it stops if you discontinue the drug. It can be really annoying for patients, though. Rash, hives, maybe 5–10% of people, usually mild. Angioedema, that's the rare but serious one. Swelling of lips, tongue, throat. Medical emergency. Dysgeusia, altered taste, especially with captopril's sulfhydryl group. Fetopathy, huge EE warning here, absolutely contraindicated in pregnancy. It can cause serious harm to the fetus. Headache, dizziness can happen. Rarely serious things like low white blood cells, cytopenia, or protein in urine, proteinuria, mostly in those with kidney disease already. And one more contraindication. The bilateral renal artery stenosis, narrowed arteries to both kidneys. ACE inhibitors can cause acute kidney failure here. So yeah, lots to consider, as we always emphasize on KMR Advise.
That's a really thorough rundown. Careful monitoring is clearly essential. What about drug interactions? Any other meds that clash significantly with ACE inhibitors that our KMR Advise audience should keep in mind?
Yes, definitely some important interactions. Diuretics, like we said, additive effect on blood pressure, risk of it going too low, watch doses. NSAIDs, ibuprofen, naproxen, that kind of thing. They can blunt the blood pressure lowering effect of ACE inhibitors and increase the risk of kidney damage, especially if kidney function is already borderline. Potassium-sparing diuretics or potassium supplements, big risk of hyperkalemia when combined with an ACE inhibitor. Very dangerous potentially. Antacids might reduce captopril absorption a bit, and lithium ACE inhibitors can reduce how the body clears lithium, raising levels and risking toxicity. So checking a patient's full med list is absolutely crucial before starting an ACE inhibitor. Basic safe prescribing.
Absolutely essential to check that med list. Okay, despite these potential issues, ACE inhibitors are workhorse drugs. What are their main therapeutic uses? Where are they most commonly used?
They really are cornerstones for major cardiovascular and kidney diseases. First line for hypertension, especially if the patient also has diabetes, chronic kidney disease, or heart failure. In heart failure patients, they literally improve survival and reduce disease progression, slow down that harmful remodeling. Post-heart attack, MI, they're standard care to prevent that remodeling too. For diabetic nephropathy, they're renoprotective, they protect the kidneys. They also slow progression of chronic kidney disease from other causes. And they're used for secondary prevention, trying to prevent another stroke or heart event in high-risk people. Their broad utility really underscores their importance, something we frequently highlight on KMR Advise.
This is a really impressive list of benefits. Now, you mentioned captopril as the prototype. Are there other common ACE inhibitors, and how do they generally stack up?
Yeah, enalapril is another really common one. Like we said, it's a prodrug, generally longer acting than captopril, might have fewer of those sulfhydryl-related side effects like toast changes. And then there are lots of others: lisinopril, ramipril, perindopril, fosinopril, quinapril, trandelapril, imidapril, the list goes on. They all share that core ACE inhibition mechanism. The main differences really lie in their pharmacokinetics, bioavailability, half-life, prodrug status, elimination route. These differences affect dosing schedules, maybe some subtle differences in tissue penetration, but the overall class effects, the therapeutic uses, they're largely similar across the board.
This has been incredibly thorough, a real deep dive into the renin-angiotensin system and ACE inhibitors. So just to quickly recap for our KMR Advise audience, we've seen how RAS controls blood pressure, fluid, electrolytes with ANG as the star player. We walked through the cascade, the receptors, how RAS goes wrong in disease, and then we really focused on ACE inhibitors, how they work by blocking ACE and boosting bradykinin, their kinetics, side effects, interactions, and their huge range of uses in heart and kidney disease. Understanding all this gives such valuable insight into common conditions and treatments, really supporting your learning journey with KMR Advise.
Absolutely. Getting a solid handle on the RAS and ACE inhibitors is just fundamental in medicine. It touches so many areas of cardiovascular and renal health.
And for all of you who found this detailed discussion helpful, please remember to check out the other great educational content on the KMR Advise YouTube channel. Do you like this discussion? Subscribe if you haven't, and definitely hit that notification bell for future deep dives into key medical topics.
Yeah, it's all about building that strong knowledge base.
So finally, as you reflect on this intricate RAS system and the impact of ACE inhibitors, it kind of makes you wonder, doesn't it? Given all the roles RAS plays, what other targets within this system might pop up in the future for treating heart and kidney diseases? It's definitely a space to watch. Lots of ongoing research, fascinating stuff.